have phone in?
Yeah.
Just join with the phone. जो PPT है आप लैपटॉप से रन कीजिएगा और आप बोलिएगा फोन से, ऐसा कर सकते हैं.
But then I also have to start the video.
या सिर्फ फोन में सिर्फ आप माइक चालू रखिएगा.
Okay, I'll just try.
At last. Yeah, Kamal, how are you? Let's go ahead. अभी क्या करना है?
हर्षिता को उनसे फोन से ज्वाइन करवा रहे हैं हर्षिता को, बिकॉज उनके लैपटॉप का इशू आ रहा था ना. सो जस्ट वेट फॉर दैट टाइम. एटलीस्ट उनके फोन से प्रॉपर वॉइस आ जाए और लैपटॉप से स्क्रीन शेयर का प्रॉपर दिखता रहे, देन वी कैन स्टार्ट विद दिस.
ओके.
देवेश जी, वेरी गुड मॉर्निंग.
वेरी गुड मॉर्निंग सर, हाउ आर यू?
आई एम वेरी फाइन सर, और आपको बहुत बहुत बधाई.
बधाई. क्या हाल है सर भोपाल के?
भोपाल बहुत अच्छे.
कब बॉम्बे में आ रहे हो सर?
मैं डेफिनेटली आऊंगा सर, आपका आदेश है. वो एक छोटी सी उस समय आदेश पूरा नहीं कर पाया था.
कोई बात नहीं,
अभी तक दिल में मलाल है. और
अरुण जी भी याद कर रहे थे आपको.
है जी. जी
गुड इवनिंग सर. गुड इवनिंग.
Harshita, please start.
A very good evening to all of you. I, Harshita Dadheech, welcome you all on behalf of Dadheech International Trade Foundation. I welcome you all to this most awaited and super informative webinar session. आइए शुरुआत करते हैं इस श्लोक के साथ. यह श्लोक हमारे DITF परिवार की प्रेरणा है.
बुद्धियुक्तो जहातीह उभे सुकृतदुष्कृते तस्माद्योगाय युज्यस्व योगः कर्मसु कौशलम् योगः कर्मसु कौशलम् योगः कर्मसु कौशलम्.
इस श्लोक का भावार्थ है कि जब कोई मनुष्य बिना आसक्ति के कर्म योग का अभ्यास करता है, तब वह इस जीवन में ही शुभ और अशुभ प्रतिक्रियाओं से छुटकारा पा लेता है. इसीलिए योग के लिए प्रयास करना चाहिए, जो कुशलता पूर्वक कर्म करने की कला है. DITF mission. Of course, every organization has got some mission. So, DITF mission is to create a community of people who come together for economic, social, knowledge, and service for the nation. DITF vision is to inspire people, to pass on the learning of our elders to our young enthusiasts and strengthen our communities. Now coming to the man behind DITF, Mr. Devesh Harishchandra Dadheech. He is the founder president of DITF and he himself is a chartered accountant by profession. He is the leader who is showing the path to thousands of people. I thank you, sir, for giving me this opportunity to be a part of this wonderful webinar. Well, this is not the first webinar by DITF. We have conducted more than 50 webinars. Which include preparing for job interviews, stress management, women empowerment and equality. Our recent webinars include how MSMEs can leverage cloud, social media, and Google business to gain needful attention, leads, and grow their businesses. Dr. Shambhu Dayal Sharma.
I think she has logged off for some network issue. Let us wait for 1 minute. I think she will log in back.
Or Shreyanjali can continue.
Bhagesh, she has been, I think, some technical reasons. I think we can do that later on. Shreyanjali, you are there, no?
Yes, sir.
I think some technical reason from Jodhpur, unka shayad kuch technical hua hoga.
Okay.
Yeah, you can start, continue.
So shall we just start with the PPT?
Doctor sir.
Hello?
Hello, yeah.
Yeah, I think fine. You can introduce.
Yes. I don't have anything prepared, but good evening, everyone. I am Dr. Shreyanjali Acharya. I'm doing my MS Ophthalmology from Rajshri Medical College, Bareilly. I've already done my MBBS from MGM Medical College, Aurangabad. Today, we are gathered here. Thank you so much, Mr. Devesh ji, for giving us this opportunity. And I'm extremely honored to share the screen with Dr. Hemant Ojha ji. Today, we'll be having a webinar on age-related problems and urological problems. So let us please start the presentation. And I would like to ask Dr. Hemant Ojha ji to start.
Thank you. Let's see if I can share my screen.
Yes, sir.
Okay, can you all see this?
Not yet.
Hello?
Not yet, sir. It's showing your bandwidth is low.
Okay, can you see the starting screen? Aging and urological problems?
Not yet, sir. You have to do the process of sharing it again with the green button that you did it earlier.
Okay. Right. Oh, network problems, yeah. Okay, let me start again. Okay, can you?
So please open the PPT on your computer, and after that you need to share the screen. There's a share screen option at the bottom of the laptop, if you can see.
I did earlier and it worked very well. I don't know what's happening.
Yes.
Can you see it now?
No, sir.
Okay, just 1 second. We tested it earlier and it was working. I don't know why.
No, there is a network issue, sir, at your system.
Okay.
There is a network
But
issue.
I can see all the lights on here.
If coordinator can share the screen.
I'm sorry, suddenly the network has gone. Okay, can you see the screen now?
No, sir.
I don't know what to do. Yeah.
Senik, sir, can you help us share your PPT on the WhatsApp group that we have? So one of us can share the screen and can do the.
Well, I've sent it to Shriyanjali already.
Yeah, okay. Shanti, if you can just post it in that.
No, I just wrote on the group. Actually, I don't have PowerPoint on my laptop. So,
No, on WhatsApp. On WhatsApp group, you can just forward if you have received the WhatsApp from sir.
Okay,
Just be fine, I guess.
Let me try again. Just let me try again.
Yeah. Meanwhile, Shanti, you can go ahead. You can go ahead and share that thing. Let's prepare in the back end till the surprise and again.
Okay.
Yeah.
Yes, sir, your screen is
started
now.
Okay, now can you see me?
Yes.
Yeah, we can see your screen, sir. We can see your screen.
Yes. Okay,
I told
there we
you,
go.
there is a network issue at you. Okay, you can start now.
Yeah, I'll sort it out. And right, I'm trying to put it on a slideshow. So you can see the
Press F5.
Is that better? Okay, thank you. Right. I'm really sorry about the hiccup.
No issue, sir.
But this thing happened. These things happen.
Yes.
And it's just like a urinary flow. As age advances, the urinary flow gets interrupted as well. Okay, so we are going to find out the causes why that happens. And the idea is that you should be able to sort it out. And that's what we have done, sorting the internet out sorting the network out. Okay. First of all, I would like to thank Mr. Dadheech for inviting me to address this webinar.
Thank you, sir.
It's really a great opportunity for me to share my experience of almost 40 years in urology with not only medical professionals, but also to share it with general public as well. I'm sure medics in the audience today will realize that it is difficult to pitch the lecture to the general forum. It is easy to give lectures to the medical fraternity because they know most of the terms. But to pitch it to a general public forum is a bit difficult, but I will try my level best. And please do, and Sri Anjali is the moderator, and I'm sure she will interrupt on your behalf to ask me some questions as we go along. And afterwards, you'll have an opportunity to ask me more questions if needed. So, aging is inevitable. It will happen, no matter what we say. But its manifestation in human beings is not universally same. So it affects the different organs in different ways, and it manifests itself in different grades in different people. So for example, things like cataract, hypertension, diabetes, arthritis, stroke, Parkinsonism, and other major diseases will happen, but not to the same extent in everybody. But it's almost desirable that we should know about it and also be aware of what ways we can prevent it, if anything. Now, aging and urinary tract has a different sort of relationship. It may affect directly, for example, its impact on the kidneys or the bladder, or it may affect indirectly due to the effect through diabetes or hypertension, stroke, or other diseases. Now, whilst all these diseases are progressive, there are treatments to alter the course of the diseases. And therefore, we should consider what are the preventative measures and what are the newer treatment which are available to control the disease process. Now, this is in general a urinary tract, which involves the kidneys, the ureters, and the bladder. So the function of the kidneys is to filter almost 25% of the blood supply from the cardiac output into the kidneys. It filters it and gets rid of all the toxins from the body through urine into the bladder. Now that process is continuous. So always there will be urine coming down from the kidneys into the bladder. The bladder, however, has other function. It functions as a storage organ where it stores urine. Otherwise, we'll all be incontinent all the time, and that is what not we want. So bladder controls the storage to a great extent, and then regularly it gets rid of the urine by contracting completely, getting rid of all the urine so that the bladder is empty after one has passed urine. The urine flow comes out through the urethra, which is the water pipe, and then it goes to the prostate. And in men, this becomes more important because that is where the enlargement produces obstruction to the flow. Now, the bladder is a very complex organ. It is controlled by lots of nerves, as you can see in this diagram, and also the transmission of a lot of neurotransmitters. So we have taken advantage of that knowledge to imply or impose some medical treatment before we end up doing surgical treatment for all.
So
now,
like
male and female urinary, yes. Sure.
Like I said, a lot of diseases which are age related, like cataract, जिसको हम मोतियाबिंद बोलते हैं, hypertension जो BP की बीमारी होती है, diabetes जो sugar की बीमारी होती है. So sir, most of these diseases अगर हम सही टाइम पे डॉक्टर के पास जाएं और उससे डिटेक्ट करवाएं, तो क्या इनके कोर्स को या उनके साइड इफेक्ट्स को हम कम कर सकते हैं?
Certainly, I think so, because earlier intervention is better. and therefore complications of many diseases can be halted.
और
ये बहुत जरूरी है
जी, और हम क्या क्या प्रिवेंशन ले सकते हैं, या जैसे हम क्या टेस्ट पहले से करा सकते हैं, या कितने टाइम पे हमको बार बार टेस्ट कराना चाहिए ये सारी एज रिलेटेड डिजीजेस के लिए? एट व्हाट एज शुड वी स्टार्ट गेटिंग टेस्टेड?
Okay, that's a very good question, and I can talk for hours on that. But today I'll try to remain focused on the urinary tract, and we'll go further ahead and talk about the relevant investigations and the relevant preventative measures, if that is okay. Yeah?
Yes.
Okay, so very quickly on each slide, I'll try to remember that. That's a very good point that you have raised. And in each slide, I'll try to tell what are the preventative measures that can be taken in relation to the urinary tract. Now, here you can see the slide of the female lower abdomen here and the male lower abdomen here. On female, you can see the water pipe, the urethra, is very close to the other organs, like the rectum and the vagina, and therefore there is a lot of cross-contamination. And cross-contamination means easy access to infection. So there's a lot of bacterial growth in the bowels, and that can easily transmit into the urinary tract. Whereas in males, the prostate and all the structure in the perineum that prevents the cross-contamination. Therefore, the very first point, the urinary tract infection as such is less common in men, and in females, it is quite common. Okay, but then the question is, who should we investigate more? The problem is that in males, if there is infection, then it is usually due to obstruction or due to stone. As I mentioned in the first slide, that a residual urine in the bladder, which means when the bladder does not empty fully, that residual urine is prone to bacterial growth. And therefore, stagnant urine or stagnation of urine can lead to bacterial growth and therefore infection. So in men, if they're not emptying the bladder, they've got infection. And therefore, that is the first sign where you have to start investigating. If a man comes with urinary tract infection, he has to be investigated. Whereas in females, up to 5 to 6 infections, we say it could be due to cross-contamination. Yeah? Is that okay?
Yes, sir.
Okay. So aging and urinary tract, it affects, I'm going to talk just on the urinary tract now. So in the kidneys, as I said, the main function is filtration of the blood to make urine, which is getting rid of all the toxin product. Now, of course, the blood that comes into the kidneys is dependent on the size of the blood vessels. So when there is hypertension, the blood flow is reduced. When there's diabetes, the blood flow can be affected as well. Okay. Now, the filtration of the kidney process in the kidneys can be affected by so many processes like the infection, the stone, the chronic glomerulonephritis, and other things. And therefore, the urine production can be reduced, and in later age, you can have renal failure. In bladder, the important thing is that bladder is composed of two things, the elastic fibers and the muscle fibers. The elasticity is lost as age advances, and therefore the bladder does not distend that much. And if the bladder does not distend that much, it is not going to store that much urine, and therefore one is inclined to go and pass urine more frequently, and therefore you have more recurrent increased frequency. The prostate enlarges in size due to its effect under the influence of testosterone. Now, interestingly, testosterone reduces as age advances, but the active form of testosterone, which acts in the prostate, that is increased quite significantly. And that enlarges the prostate. That causes obstruction to the flow of urine by compressing on the water pipe, goes through the prostate, and also irritates the bladder. The cancer of the urinary tract, they are all common above the age of 50, except in testicular cancer, which is usually in the ages of 20 to 40. And the cancer, the two common things that we have found having a direct link to urinary tract cancers, number one is smoking. So chronic smoking and chemical dyes. There are many other factors, familial history and all those things, but these two are quite relevant, and therefore avoiding smoking and avoiding exposure to benzene-related dyes is very important. Now, both testosterone and estrogen production reduces as age advances. We know in postmenopausal women, the estrogen level goes down, and therefore there is a risk of urethra, the water pipe, getting narrowed, and therefore they get retention, and therefore they can get recurrent infection. So that is one thing that one has to be aware of. And the testosterone production, as I said earlier, relates to the enlarged prostate gland. Now, interestingly, it is responsible also for benign prostatic enlargement as well as for prostate cancer. Okay, can we go to the next? Yeah, any questions?
So इसमें सिर्फ स्मोकिंग की वजह से कैंसर ज्यादा होता है या फिर अल्कोहल इंटेक और भी कोई एक्सपोजर चीजें हैं जो हमको अवॉइड करनी चाहिए?
Okay, alcohol has not been shown to be directly involved with any cancer of the urinary tract as such. But of course, we think that those people who drink a bit of beer here and there have a better flow of urine. So that is interesting. I'm not recommending that everybody should have it, but that is there. Smoking, yes, definitely. Smoking has a relationship. And if somebody is diagnosed with bladder cancer, and if they don't stop smoking, the disease progresses, definitely. And occupational hazard is, occupational hazard is exposure to benzene-related dyes, which were used quite frequently in rubber industry, especially in Birmingham, when in early 1950s, when we found out that there was a direct relationship, and that was stopped.
And अगर कोई पहले से स्मोकिंग करता है and they stop now, तो will it have a good effect? और पहले से स्मोकिंग कर चुके हैं तो there's nothing you can do about it?
Okay, there are 2 or 3 ways of looking at it. Something is, all smokers don't have bladder cancer, but they have a high risk. Okay. Number one. Of course, when you sort of stop smoking at whatever age, you run down the risk of getting cancer proportionately. But still, the original trauma has been done. You know, there's a 2-hit theory for cancer development. One is that we always have a genotype and a phenotype. So the genotype means that genetically we are predisposed to some forms of cancer. And the environmental influences acts like a second hit. So we'll have to think of that. Okay.
And so someone in the audience had a question that, as you said, with age, prostate increases in size. So is there something we can do to not let the prostate increase in size with age? Are there any precautions we can
take? Yeah. So as I said, there are 2 types of medical therapy. One which acts on the nerves and the muscles of the prostate. Yes. We call them alpha-adrenergic blocking agent. And that improves the flow. So it removes the spasm of the prostate. But the other one is 5-alpha reductase inhibitor, which reduces the size of the prostate gland as it goes. Now, I don't know what they're called in India, but here we call them Proscar. I think it is Fincar in India. So if you have that, then of course it reduces the size of the prostate as age advances. And that is almost up to 20%, 20 to 40% it can reduce. But there are 2 problems with it. One, it causes impotence. Number 2, it can also cause a development of prostate cancer. Therefore, it is not routinely recommended for everyone. But of course, if we find that somebody has got significant symptoms and a very large prostate, we give it to reduce the size.
And another person had a question कि जैसे आपने बोला कि बढ़ती हुई उम्र के साथ में above 30-40 elasticity जैसे loss होती रहती है, उसकी वजह से frequent urination होता है. लोगों में, बट अगर ये यंग एज में हो रहा है तो व्हाट कैन बी द प्रॉब्लम, और शुड दे गेट टेस्टेड फॉर इट?
Yes. So first of all, the first question should be, what is normal frequency? And the normal frequency is up to 6 to 7 times in 24-hour cycle. And we'll discuss that in this slide. But yes, if it's an earlier age, then it could be due to an overactive bladder syndrome, where the bladder muscle is contracting too fast. And that may be under the influence of central nervous system or peripheral nervous system. So we need to look it up. Here we tend to, in UK and Western world, we tend to make sure that somebody is not suffering from multiple sclerosis and other neurological symptoms.
Okay.
In elderly, one has to rule out Parkinsonism as well, if they've just got irritative symptoms but no obstructive symptoms. So just that takes me nicely to the next slide, which is just what are the urinary symptoms that we should be aware of. Very interestingly, we define the urinary symptoms into two categories: storage or irritative symptoms and obstructive or voiding symptoms. So irritative symptoms are frequency, urgency, and nocturia. Frequency is getting passing urine more than 7 times a day. Urgency is a very intense, strong desire to pass urine, which means you have to go there and then. Normally, we are all very good social animals, so we can decide. If you're driving, you can hold your urine for up to 4 hours or so. Okay, so you don't need to go to the toilet for up to 4 hours, 5 hours. But then, of course, if you have a strong urgency, then you have to stop and you have to go to the toilet. And therefore, you can see so many people on the roadside passing urine, maybe because of urgency or because of habit, I don't know. But probably, I would like to think it's because of urgency. Nocturia is getting up more than once in the night to pass urine. Now, you should not be getting up in the night to pass urine, except one occasionally, if you've had a drink, tea, coffee, or any other things later on in the night. But otherwise, you should not be getting up. And that could be related to so many other things. I need to rule out cardiac failure in that, because in cardiac failure, people, the first symptom also is nocturia, which is getting up too often in the night, because they have a lot of fluid in the third vascular space and interstitial space that gets absorbed into the vascular compartment, gets filtered in the kidney in the night, and then we have more urine production. Normally, we are protected by antidiuretic hormone, which is protecting us from getting up too often in the night, because we make less urine in the night. Okay. Now, so these are the irritative symptoms, which means they are affecting the storage function of the bladder. The obstructive symptoms are poor stream, hesitancy, and burning in urine. Burning in urine is usually an indication of infection. Poor stream and hesitancy could be either due to enlarged prostate or due to stricture of the urethra. But more importantly, people are now talking quite a lot about incontinence of urine, because they leak urine, and it is such an unsociable act that makes our life miserable. You know, the need for pads, the need for frequent urination, going to the toilet, and all these things, they are a nightmare. And we'll talk about that in a separate slide. The most important urological symptom that I would like to be aware of is hematuria, which is blood in urine. If you have ever passed blood in urine, please get yourself checked by a urologist to ensure that you do not have any cancer of the urinary tract. And then the pain and mass or lump in the testicles or in the kidney area, they are self-explanatory.
Okay. तो बेसिकली अगर हमको बार बार यूरिनेशन के लिए जाना हो, या फिर हम कंट्रोल नहीं कर पा रहे हो अपना यूरिन, या फिर हमको रात को बार बार उठना पड़े फॉर यूरिनेशन, तो ये सारे सिम्टम्स. एंड अदर देन दैट, अगर हेजिटेंसी है या फिर जैसे पेन हो रहा है वाइल यूरिन, अगर चल रहा है यूरिनेशन के टाइम पे, तो तब हमें डॉक्टर के पास जाना चाहिए. एंड सर, hematuria, which is basically अगर आपको red urine आ रहा है, तो does that always mean cancer या फिर वो कोई और भी urological problem हो सकता है?
Okay, so studies have shown that 25% of cases of hematuria will have cancer as the cause, cancer of the urinary tract. There are other medical conditions which can cause hematuria, which is blood in urine, and that could be things like patient may be on warfarin or something, any of the blood thinning tablets. It could be due to other diseases like hemoglobinopathies and other things. It could be due to infection itself in the urine, and therefore, but we still need to investigate fully. Here, we first try to, we are so worried about the symptom that in UK we have a special cancer detecting service for the 2-week wait, we call it, which means any patient with blood in urine has to be referred in our 2-week wait cancer referral pathway so that they are seen within 2 weeks and investigated within another 2 weeks to make sure there's no cancer. After that, we can sort out in a different way. If we rule out cancer first, then we can look for other causes. It could be due to stones, it could be due to enlarged prostate itself, it could be due to so many other things. Hemophilia, so many things come to mind.
तो सारे symptoms में सबसे ज़्यादा important है blood and urine, जो कि normally लोगों को red urine मिलेगा या फिर थोड़ा और dark colored urine हो सकता है, black urine. तो उस time पे immediately doctor के पास जाना चाहिए, check करवाना चाहिए कि क्या cause है. Okay.
There are 2 or 3 other things as well. Some drugs can give rise to blood in urine, like pyridoxine was one. And then the other one is one of the anti-tubercular drugs. And then we also have blood. If you take a lot of beetroot, the urine looks red. It's not blood in urine, but it is red urine. Okay?
And sir, last question, sorry. But you said, so ये pain basically कैसे पता चलेगा? Which kind of pain या कौन से area में pain होना body के that we can think ये urinary symptom हो सकता है या कोई urinary tract का infection होगा?
Okay. So the commonest pain that we come across is what we call as a renal colic, which is pain arising from the loin going into the groin. So loin to groin pain, it is sharp, it's colicky. It is almost comparable to labor pain. And when it comes, it really disturbs you. It can disturb people who are driving or flying or whatever. And it is very important, but that is usually due to stone. Very occasionally, it is due to blood passing down from the kidney into the bladder. But other type of pain is in the bladder area, just above the pubic bone, suprapubic area, as we call it. And that could be due to constant dull ache of the infection when the bladder's got infection in it. Sometimes you get pain in the testicles as well due to infection in the testicles. So mostly either pain or stone. Cancer usually does not give rise to pain unless the pain is in the bony part, and that comes from prostate cancer. So in the backache, okay? And the mass is usually like a mass that you feel in the kidney or in the testicle. Okay, so a bit talk on prostate, and it enlarges in everybody after the age of 40, okay? But only 30% will require treatment in case they develop symptoms. So 30% will develop symptoms, and that is bad enough to warrant treatment. Otherwise, 70% will just have prostatic enlargement as a process without causing any problems. And we know that 2 things are very important: aging and testosterone hormone production. That is important. We know that there are people, if they've been castrated before, castrated meaning the testicles have been removed before the age of puberty, then they will never have prostate problems at all. But that's a very high price to pay for the prostate enlargement. 1 in 10 in the Western world will have prostate cancer. That is for sure. Now the statistics in India, I'm sure you'll be able to tell me, in a minute. But in UK, about 58,000 people die of prostate cancer every year. And we are trying to find out ways of reducing that mortality. Now, commonly believed that many people die with the disease rather than due to the disease. And that is an important statement. That comes from the fact that people who have had the postmortem done above the age of 80, almost 70% will have prostate cancer histologically present in the prostate gland. Whether they are in Japan, whether they are in India, whether they are in the Western world, universally the same figure exists. But the clinically manifested prostate cancer changes in different countries. The incidence changes quite a lot. In Japan, there is hardly any prostate cancer. In India, there is low, but it is coming up. In Western world, it is quite a lot. And my next slide will show you the incidence in a minute. Okay.
I would like to tell everyone that India में जो new cases है prostate cancer in the year 2022 were 2,68,490, and mortality rate मतलब जितनी deaths हुई हैं because of prostate cancer in 2022 is 34,500.
So if you look at the wider population, it's quite small figure. Indian population 1.5 billion, if I'm right. So 38,000 deaths only. And that too, the problem is that most of the deaths are probably happening because they're picked up very late. Okay. And that was my experience. When I was
a lot of people die with the disease rather than being detected. So that is also a case.
Exactly. So basic preliminary test for urinary tract, urine microscopy to see whether there's infection, red cells or white cells, blood test for kidney function test, an ultrasound scan of the kidneys and the bladder, and a flow rate test. That is very important to a urologist to rule out prostate causing obstruction or not. And the PSA has now become almost mandatory in everybody who comes with urinary tract symptoms above the age of 50, in a man, of course. And that PSA stands for prostate specific antigen. It is a protein uniquely secreted just by prostate gland. Very occasionally, we have found some evidence of it being secreted elsewhere, like the salivary glands, but mostly from the prostate gland. And it is not cancer specific, but it is organ specific. Okay. However, we have done a lot of studies, and I did a lot of study work on PSA before, and I did a thesis for is prostate cancer, prostate specific antigen, an effective tumor marker. And my conclusion was that it was a very good marker for follow-up of prostate cancer, but for diagnostic, we needed some more other features to add to it to make it a very useful tumor marker. Certainly, the level in the blood relation to the age is very important.
So prostate specific antigen जैसे आपने बताया blood test, तो कितना frequently हमें कराना चाहिए या किस age पे males को start करना चाहिए ये test कराना?
Okay, right. So there are two things to consider. One is, should it be offered to everybody? Which means all the population at large, and that is called screening. And we don't advocate that. Why we don't advocate that? Because the pickup rate for prostate cancer in a general population is less than 3%.
Okay.
And PSA is not the only diagnostic test. After PSA, you need to have a prostate biopsy, which is painful, which has a 2% risk of infection leading to mortality. And therefore, we don't recommend it to everybody. We, however, do recommend it in certain groups of people. Number one, those who have got urinary symptoms.
Okay.
Number two, those who have got chronic backache, which has not been resolved by any other means, to make sure that that backache is not related to prostate cancer. Number three, those who have a family history of prostate cancer. And number four, there are some patients who have read a lot in the media, and therefore they want a PSA test. You can't refuse them. If they want it, they have it.
See.
And how frequently? I think if the first test is normal, then maybe annually.
Okay.
But that has to be compounded with the digital rectal examination of the prostate gland.
Okay. तो अगर आपको prostate cancer की history है family में, या फिर आपको back है जो बाकी medication से या उसका कोई cause नहीं पता चल पाया और resolve नहीं हुआ है, तो हम ये test करवाएंगे. और उसके अलावा अगर आपको कोई भी यूरिनरी सिम्टम्स है, जैसे कि पहले बोला फ्रीक्वेंसी हो गया, हिमाचूरिया एंड अर्जेंसी, नॉक्टूरिया एटसेट्रा, तो तभी हम लोग ये टेस्ट करवाएं. और अगर करवा रहे हैं नॉर्मल आया तो भी एनुअली हमको हर साल ये टेस्ट करवाना चाहिए.
But that should be, in that situation, it should be done above the age of 50.
Okay.
Not in young men, because you'll never, I mean, I have found only 1 or 2 cases of prostate cancer below the age of 40. But that too, there was a strong indication that they had a family history. And therefore, by doing the PSA test, we picked up early prostate cancer there.
But prostate specific antigen agar zyada badha hua hai, to it does not always necessarily mean prostate cancer, right?
Very good question. And PSA is raised in 3 situations. Number 1, just merely the size of the prostate gland.
Okay.
So every bit of epithelium cell of the prostate gland produces PSA. So it's a mathematical assessment that the more gland is there, the more the PSA would be produced. Number 2, in infection of the prostate gland, the PSA goes into the bloodstream more readily, therefore it can be raised. And number 3, is it in cancer? Now, if it is due to, so the main important thing is what is what. If there's any sign of infection, you should not do a biopsy because that will kill the patient, basically. If there is infection, then you should treat with antibiotics, repeat the PSA, repeat the ultrasound scan, and then reassess.
Okay. And the number of tests that you just mentioned, are all of them necessary, or only a few of those can be done and it's a good way to go?
So the initial screening tests, those are, say for example, I have my own ways of doing it. Ultrasound scan can be difficult in every situation. I rely quite heavily on bladder scan. There's a little small gadget, just a bladder scan, which you just put on the suprapubic area, and that gives me an idea what is the residual urine. If it is less than 300 mils, there's no need, and the creatinine is normal, kidney function is normal, you don't need to scan the kidneys. But if you can get a scan of the kidneys and the bladder, it's good. So I would say almost essential, all of them.
Okay, so fine.
Because it can be a screening. Otherwise, generally what I see when I see many reports coming to me, they've already had CT scans and other things before even having the preliminary tests. I think we should go step by step. CT scan is radiation, lots of radiation. Ultrasound scan is jelly on the belly. There is no radiation, nothing.
Okay.
Okay?
Yes.
So just very quickly to recap, benign prostatic enlargement, also known as benign prostatic hypertrophy or benign prostatic hyperplasia, is not cancer, but may not cause symptoms either. But in 30%, it may cause bad symptoms to get treatment. The worst scenario is developing retention of urine, and that is acutely painful. And that time, if you don't have a catheter, the world comes to an end for that patient that way. But sometimes it can be a chronic retention, which means the bladder slowly distends, keeps on distending. The muscle loses its power, and therefore it just keeps on distending, and you hold up to 1 to 2 to 3 liters of urine, and that can cause back pressure effect on the kidneys, and that can lead to renal failure. Mild symptoms, no treatment. If it's not affecting with the quality, remember, this is not cancer, so treatment is not necessary unless the symptoms are affecting the quality of your life. And this is an important pros and cons that comes into the situation. So mild symptoms, no treatment. Moderate symptoms, you give medical treatment with the tablets that I alluded to earlier. And severe symptoms, we look for surgical intervention. We used to do transurethral resection of prostate routinely, but that incidence has reduced significantly. We're now relying on medical treatment mostly, If not, then by laser or then surgical enucleation. Resume is the new one that has come out, which is hot steam going through the endoscopic channel into the prostate, hot water steam. So switching on to prostate cancer, anything on benign prostate enlargement? I think we are fairly okay with that.
Covered everything.
Yeah. So prostate cancer, you can see the incidence. We have discussed it briefly. Quite common in America, Northern America, and mostly in African blacks living in Northern America. Very low in China, you see, and Japan, maybe due to dietary influence, probably because they have a lot of soya in their diet, and that sort of protects the prostate from developing into cancer. But in India, the incidence is coming up. I think more importantly, if you look at it, most of the countries maybe are not doing PSA tests regularly, and therefore we are not picking up prostate cancer regularly. So that may be. So this data is old, and therefore we need to rely on newer data, which will be coming through soon. It takes about 10 years for the data to mature. And we have to wait for that to come through. Now, prostate cancer, yeah.
One question, sir. Like you said, that maybe they have protein in their diet. Because of that, उनमें cancer कम मिलता है, prostate cancer. तो और कुछ चीजें हैं जो हम खा सकते हैं जिसकी वजह से हम avoid कर सके prostate cancer.
Okay, yeah, there are two other things. One is pumpkin seeds. Pumpkin, कद्दू के बीज. मैं यहाँ पे बहुत लोगों को कहता हूँ, I tell them to put them, they are available as fresh, as sort of stored seeds. So you can sprinkle them on your cereals, and that is supposed to be good for the prostate. Zinc is good, zinc, selenium, and other things. They are all antioxidants. So they are anti-scavengers, sort of thing. They're scavengers, and they take away all the bad oxidants away, all the bad nutrients away, things. But other thing which also is very good is pomegranate, which is anardana. Anardana, not the churan. I don't know about the churan bit, but the anardana seeds. They're very good. They're very, very good. Almost every salad here you will find pomegranate seeds. Pomegranate juice may be a good idea as well, I think. So very quickly, yes. Any question coming? No. Okay. So prostate cancer, very quickly, we do the PSA, we do the rectal examination. But the biggest achievement that we have seen recently is that we do MRI of the prostate on everybody with abnormal PSA before subjecting them to prostate biopsy. Before that, we were not doing it. And in the MRI, we can identify an abnormal area where we can target that and also take random biopsies from the rest of the gland. So it is difficult to find prostate cancer on needle biopsy, but that is the only thing that we have at the moment. But once you diagnose prostate cancer, then we do a CT scan, bone scan, biopsy grading, and radiological staging to find out whether the prostate gland cancer has spread outside or not. The new latest development is additional of PET scan, and that will also help in finding out whether there is lymph node spread and other spread as well, other organs.
But MRI, CT scan, PET scan, इन सब से बहुत ज़्यादा radiation होती है, तो ये frequently advice नहीं किए जाते हैं ना?
Okay, MRI is radiation free. MRI does not have any radiation.
Okay.
Okay, so MRI is therefore very safe. So we do transrectal ultrasound scan or transperineal ultrasound scan. But if we do an MRI, we can see the prostate, we can see the size of the prostate, we can see the anatomy. Can you see the picture of the MRI there, which is there? And you see a needle going through that abnormal area.
Yes.
That is going to be a target area. 40% of the time we'll find prostate cancer there. But we will also find prostate cancer in the surrounding areas when this may be negative. And therefore we have to combine the both together.
Okay. And
so
sir,
that is the important.
Okay. Someone has a question about if someone is diagnosed with BPH, then what should be the treatment followed?
Okay, so it depends, as I said in the earlier slide, if the symptoms are very mild, you don't need any treatment. But if the symptoms are moderate, trying to affect your symptom, quality of your life, trying to affect your quality of life, then of course you need medical treatment to start with. To say there is a tablet, we call it Flomax, I don't know what's called in India, one of the tamsulosin products, and that is very good to improve the urinary flow. But if the PSA is normal and if the prostate gland is big, then you can give finasteride or Fingar. But if these two fail and symptoms progress, and we judge that by doing some objective tests like the flow rate and the ultrasound scan, then we do recommend treatment like laser or hot steaming of the prostate.
Okay. And Mr. Shailendraji asked, what is the thumb rule to measure urine flow?
What is the?
Thumb rule to measure urine flow.
Okay, yeah. It's very difficult. You need a flow rate test, of course. But many times here in the clinic setting, we have to ask a question to the patient. Can you, when you pass the urine, can you, and this is for men, of course. So ladies, close your ears. But can you hit the wall, back wall in a stand-up toilet? So is the flow good enough to reach the back wall? And that's a good way to judge whether you can pass a good flow or not. There are 2 or 3 other ways. I won't go into details on that because you've got general public.
Okay. Mr. Bipul Ghoshji is asking, how about frequency of urination increases and quantity reduces? Doctor finally advised cystoscopy and dilation.
Sorry, say that again.
He's asked about the frequency of urination. How about
what is frequency?
Urination increases and the quantity reduces. So like he frequently has to go for micturition and the quantity of the urine has reduced. So what to do then?
Okay, yeah. So the first thing, what is his age? Number one, the age of the patient is important. If he's in the non-prostatic age group, it means earlier, younger. I would like to do what is known as a frequency volume chart. Okay. So I would give him a frequency volume chart, which means every time you pass urine, you measure how much urine is coming out. The average functional capacity is how much urine everybody passes at each time, is usually about 300 mils. If it is less than 300 mils, then it means that the bladder capacity is reduced. Okay. In which case, a cystoscopy is necessary to see whether there is some pathology causing problem. You will also need some other test called urodynamic test, which I have not mentioned here because it makes the lecture a bit more complicated. But that is if the flow rate is not good, then you need to do urodynamics, which is a physiological way of testing to find out what is the bladder pressure at the time of passing urine and how does the bladder behave when the bladder is in the storage capacity mode. So those 2 things are important. So at that age group, you need all these investigations, definitely.
And Mr. Subhashji is asking, does treatment of DTH prevent progression to malignancy?
Yes. So a lot of studies have shown, there was a famous MTOP study from America, which showed that if you take finasteride, then that halts the progression of the disease to a certain extent, but not necessarily true for everybody. If you take a combination treatment, which is finasteride and one of the Flomax tablets or one of the variants of that, then of course the symptom improvement is significant. And therefore they think that the chances of having surgery is also reduced. But it depends from patients to patients, size of the prostate and the degree of obstruction to start with. Now, I can tell you one thing from my experience, that when I started doing a lot of urology procedures and things, way back in 1980s, we used to do TURP on anybody who had obstructive symptoms or obstructed flow. Mm. So much so that we were doing almost every theater list used to have 4, 5, 6 patients. Now we do 1 in a month or 2 in a month, something like that, TRP, because medical therapy has almost taken over. So therefore, it is a good sign. But of course, we are doing more cancer surgery, which I'll talk about in a minute.
Okay, and actually, it's not Mr. Subhashi, it's Dr. Subhashi. He's himself a surgeon. So welcome, sir, to our session.
Yeah. Oh, hi.
We can continue.
He's gone. Okay. Right.
Hello.
Well, I know him very well. He's very good. I met him last
Hello,
time.
Hemanji.
Hello. Hi.
Hi, how are you?
I'm very well. Nice to see you. Nice to see you.
Nice to see you. It's, I think, 4 years since we met. In 2018, I came to your place.
Yes, you did. Yes.
Yeah. Great. Continue to talk. I don't want to interrupt. It's very informative and very useful. Please continue.
Okay.
I'll catch up with you later.
Okay. Brilliant. Thanks. Okay. So the next one, now, obviously, if you have diagnosed prostate cancer, you need to know how to treat it. And we define it into low, medium, and high risk if it is localized prostate cancer, which means it has not spread outside. But if it is metastatic, which means spread outside into bones or lymph nodes or whatever, then the management is different. Surgery does not have a big role there. In the low risk, which means if the PSA is less than 10 and the Gleason score, as you call it, is one way of scoring prostate cancer. If the Gleason score is less than 6, then we don't need to do any treatment. We just need to monitor the disease with regular PSA and regular assessment. But if it's moderate risk, that is where we have made a lot of difference by surgical treatment. So by radical prostatectomy, as we call it, and also by radiotherapy. Now, radical prostatectomy has undergone a lot of changes. Initially, when we started in 90s, it was quite a bloody operation, as I would say, because there was a lot of blood loss and everything. But over the years, we refined the technique. The blood loss was down to minimal, and we were able to reduce the complications of stricture and also of impotence quite significantly that way. Radiotherapy has also undergone a lot of changes. Previously, it used to give a lot of bowel irritation symptoms and other things, but now it is 3D conformal radiotherapy, and therefore the side effect profile is very low. In high risk, we prefer to give radiotherapy first and then see if there is a surgical option required later on. But I must say surgery becomes very difficult after radiotherapy. If I have the choice of discussing treatment, I would discuss surgical treatment first rather than radiotherapy first. But there's no head-to-head study to say which is better, but there is comparable study to say both radiotherapy and surgery have got equally, if not good results in both the arms. Okay. So hormone therapy is by reducing the male sex hormone in the body by injections called Zoladex or Prostab injections, or also in India, maybe it is just orchidectomy, which is a very easy option to do it. But it does have psychological side effects. Chemotherapy is for those patients who have recurred despite the treatment, hormone treatment by metastasis. So with hormone therapy, after any treatment for metastasis, also the PSA comes right down to 0.008, which is fantastic news. But after 1.5 years to 2 years, the PSA starts to rise, and that is when chemotherapy becomes helpful.
So sir, अगर किसी को prostate cancer detect होता है and if their given doctor already just advises कि आपको surgery करानी चाहिए, so what do you think, should everybody go for a second opinion or a third opinion always, या फिर if you trust the doctor just go for the surgery directly?
Yeah, very, very good. I think the first opinion is of the doctor, the second opinion is of Google as well, isn't it?
Yes.
And the third, because there are lots of sites where you can have risk stratification done. So if I get almost one call a month from India about discussing prostate cancer or bladder cancer options, treatment options, and all those things. And I ask for various other factors. And the important thing in prostate cancer would be, I would say, what is your PSA? What is your Gleason score? What is the extent of the spread? And then I will decide based on that. So there's no harm in getting second opinion. Here in our system, what happens is that most patients come fully informed. We give them choices. After the diagnosis, the first person to give the news to the patient is usually a clinical nurse specialist. And he or she gives the diagnosis, the diagram, and with all the relevant features and the important message about what sites to go. UK prostate cancer site is a very good one, and that you can go there, look at it. These are your findings, your PSA, your Gleason score, and all those things, and then you can just carry on with that. And they will give you the options, and they will give you the risk stratification to say, if you have surgery, this is your chances of benefit, and with radiotherapy, this is your chances of benefit, or this is the chance of recurrence, that way. So it is very important. That
also, so a lot of times biopsy is recommended by the doctors and the patients are a bit hesitant कि हम biopsy के लिए जाएं कि नहीं जाएं. तो क्या हमें हमेशा biopsy करवानी चाहिए या फिर नहीं?
Lovely question. Lovely question. And this is important. I would only in one situation say biopsy may not be necessary when the PSA is, say, more than 100, when I know for sure that it has spread into the bones and therefore hormone treatment is of importance. But 9 out of 10 times, I would never treat a prostate cancer without a biopsy result. It is very important because that's how you're going to identify. Now, look at the other side of the coin. You have a raised PSA, somebody's PSA, a normal PSA is up to 4, maybe an age specific is slightly different. But if you take a ballpark figure of 4 nanograms per mil as a PSA cutoff value, then at that level, after that, if you take a biopsy and the biopsy is negative, does it mean he's got no prostate cancer? No, it doesn't. It just means that you have not found it. That's what I believe. And therefore, we may have to, sometimes we find prostate biopsies after 2nd, 3rd, 4th biopsies even. But MRI has certainly improved the situation. That is for sure.
Thanks.
Okay. So I just want to touch what is new because otherwise prostate cancer, again, you can talk for days on it. But certainly we have a better understanding of the role of PSA, as I alluded to. Screening is for selected population only, which means patients with familial prostate cancer or those who've got a family history of prostate cancer. Better diagnosis with trust-guided machine. Previously, we used to do digitally guided, which means just on the finger, you pass a needle and you take a biopsy and you get it. So it is a hit and miss, high chances of failure. But here we have got an MRI result, we've got a transrectal ultrasound scan or transperineal ultrasound scan, and take some very targeted biopsies as well. Use of MRI and PET scan for diagnosis and staging, that is important. 3D conformal radiotherapy reduces the side effects, and now robotic radical prostatectomy is the ultimate choice now. And you see a picture here, the surgeon is sitting here in the console, the patient is lying on this side and with the laparoscopic ports put in, and the surgeon is just manipulating the structures in the body to take the prostate out. So what does it do? It gives you a 3D vision of the prostatic. It is one of the most difficult operations to do in urology. There's a long rising curve as well, long learning curve, and but to learn it is very, very difficult. But with robotic, the vision is so good that it is making life much easier. The blood loss has been minimalized. the anastomosis between the urethra, the water pipe, and the bladder is good. And we can save the nerves going to the penis so that the erections can be preserved in some patients. That is robotic, that is the ultimate. Now, enough of cancer, if that is okay. I'll come to this very common topic, which many people would like to hear about, and that is urinary tract infections. I think almost every female has suffered from urinary tract infection at any stage of their life. Okay, mostly either due around the menstrual cycle or in the postmenopausal stage, or due to various other reasons as well. And the symptoms are burning and micturition, which is avoiding urine, pain in the loins sometimes if the infection has gone to the kidneys and you can't. Some patients can be very ill if the infection goes into the bloodstream. And therefore, it is very important to realize that somebody is suffering from urinary tract infections. There are newer antibiotics which have come up, but there are also quite a lot of preventative measures which are available. The first thing is hydrate yourself, drink plenty of urine, because the more, not urine, I'm sorry, plenty of water, because when you drink plenty of water, you dilute the urine. And when you dilute the urine, the bacteria gets diluted as well. And therefore, there's chances of it being excreted out very quickly. Second thing is we prescribe cranberry juice quite a lot. I don't know if people in India have it or not, but it is quite a good way of preventing adhesion of the bacteria onto the bladder mucosal wall. So that is very good, cranberry juice. So simple urinary tract infection, you can use these two measures. But then if infection is a bit more severe, then you do need antibiotics. And there are different courses, 3-day course, 5-day course, 14-day course, or 3 months course, and also rotational antibiotics. But they are better given by the medics, so by the doctors who can define that. Vaccination against E. coli infection is on the horizon. It will come. And it is about to be launched, I think, within a couple of years, or it may have been launched already, but it is there. But certainly surgical treatment is available for certain situations which are the cause of urinary tract infections. For example, if there are stones, if there is one of the problematic areas is that when there is an abnormal connection between bowel and the bladder internally, that causes recurrent infection, and that can go unnoticed. And I've seen quite a lot of vesicocolic fistula being the cause of recurrent infection, and surgical treatment of that can rule out infection for future. So that's about it. In men, usually we get infections due to obstructed urinary tract, due to enlarged prostate or even prostate cancer, or due to stones, from stones in the kidneys or in the bladder. The types of stones that we get in India are mostly in children, are usually due to uric acid, and that is due to nutritional deficiency. Whereas in adults, usually it is due to infection, recurrent infection. There's a nidus of infection in kidneys, and then the stone calcification happens alongside that area. Okay, any more questions on urinary tract infection?
Urinary tract infection अगर females में होता है most commonly, तो बहुत डरने की बात नहीं है अगर हम टाइम पे डॉक्टर को दिखा के ट्रीटमेंट ले.
Of course, yes. So in
like
men,
females actually do it.
Yeah. So in men, if there is episode of infection, he needs to see a doctor, a urologist, because you need to rule out outflow obstruction or stones. In females, if say there's no hard and fast rule, but roughly I say if there are 4 or 5 infections and they can be just managed conservatively. If it becomes a recurrent problem, because that could be due to either reinfection or recurrence, and that means that you're not able to get rid of the bacteria, then you need to see a doctor. But 3-4 times, I think it is okay.
And
But of course, you need to know the timing of it.
Yes, sir.
You need to know the timing. If it is, if there's a precipitating factor that it is related to menstrual cycle or in postmenopausal, then estrogen. We give a lot of estrogen creams to help dilate the urethra. That works. Or sometimes we do urethral dilatation of the females.
Yes, sir. And some females have frequent urination. So does that always mean UTI, or it can mean something else?
Yes, it can mean something else, because for that you have to have a urine test. So we do not test, we do not give antibiotics unless there is positive proof of infection.
So a urine routine should be done agar aapko baar-baar frequent urination ka
Absolutely, absolutely,
Okay,
absolutely.
And so Dr. Subhash ji wants you to, Dr. Subhash ji wants you to tell us something about postmenopausal urethral syndrome.
Okay, postmenopausal, what happens is that the postmenopausal, sorry, say that again. Postmenopausal UTI, is that what you're saying?
Urethral syndrome. I think Dr. Subhash ji can directly ask the question if he wants.
Yeah. So postmenopausal, we know that the estrogen level goes down, and estrogen has been recognized to be very important for the urethral.
Hello.
Yeah. Yeah. I can hear you.
Urethral syndrome. I'm talking about urethral syndrome. Yeah, I'm just
Okay,
asking you to close
frequency. Yeah. So we do see many times that they don't have infection, but they have frequency dysuria syndrome. So there is a lot of frequency and there's a lot of urgency. And then when they pass urine, they gets a burning desire. And but when you do the urine test, there is no infection. These patients, difficult to treat, but sometimes we have found that they respond well to urethral dilatation on its own. And sometimes we also try other medication like intravesical, cystistat therapy and other things. So but they have to be investigated fully. They need a cystoscopy, they need a urodynamics test if the urine culture is negative. Okay. Next, just coming back to urological cancers. So cancers of the kidneys and the bladder are getting more common. Smoking and exposure to chemical dyes has a strong link. Hematuria is the commonest manifest. This is some takeaway slide that way. And depending on the stage and grade, most cancers are treatable. That is the good thing about urology cancers. And cancers of the testes are common in men between 20 to 40 years of age. Almost 90% are curable as well. So it's a very good thing as long as they are spotted early. Now, urinary incontinence, it's a very big topic, but I'll try to address the issue in a succinct way. So one is involuntary leakage of urine, which we call a stress incontinence. Most commonly seen after prolonged labor or any components of surgical operation. For example, after prostatectomies or after any of the perineal surgery, that way. Now, that means whenever a patient coughs or sneezes, then there is leakage of urine. That can be treated first by physiotherapy, if not by newer methods of slings and tapes. And thirdly, if not possible, then if not relieved by these things, then they can have artificial urinary sphincters. Second type of leakage is overactive bladder syndrome, when they have a lot of frequency and urgency, and the urgency is so strong that they cannot reach the toilet in time. They have to go and pass urine straight away. Now that can be treated by medications. We give anticholinergic drugs. We try here oxybutynin or Vesicare or one of the newer drugs, and then they work very well. But sometimes physiotherapy works as well. The other thing that we work out is overflow incontinence, which is usually when you have a distended bladder and people dribble urine continuously after that. And that is usually resolved by catheterization followed by prostate operation. All of them need full investigation and specialist management. So you cannot just take it for granted. Depends, we do a pad test for stress leakage, which means how many pads are you using in a day to keep yourself dry. If it's one pad or two pads, then maybe just physiotherapy, but more than that, you need some treatment. And treatments we have discussed. So just a hint on all the preventative measures, which we have already discussed. Plenty of fluids up to 2.5 liters per day. Avoid smoking and exposure to chemical dyes. Prostate healthy foods like pomegranate seeds, pumpkin seeds, rye, and dried tomatoes. I don't know what's the Indian word for rye. I know what it is here, what it looks like. But dried tomatoes is very good, sun-dried tomatoes. And then there's a lot of debate about PSA test, who should have it, who should not have it, why should I have it, how often should I have it, and that goes on. But again, you need a specialist view on that. And I would like to thank you, the organizers and everybody, for your patience.
And sir, a lot of people have questions about related to kidney stones. So it is a very frequent issue. And so if somebody has had a lot of episodes of kidney stones and have been treated medically for it, so can they do something to avoid kidney stones in the future? And कितने mm का stone हो तो हम उसको निकाल सकते हैं instead of surgically?
Yeah, so kidney stones I deliberately didn't touch on because otherwise we could have gone on and on and on. Anyway, but basically it depends on what type of stone it is. Is it a calcium-based stone, calcium oxalate, calcium urate, or infection stones? So if it's calcium oxalate type of stones, then you of course have to avoid calcium in your diet and oxalates in your diet. Spinach, tomatoes are rich in oxalate. Calcium, protein, milk, dairy products, they are rich in calcium. So they have to be avoided. Now, I would not recommend that they should be completely taken off. That's bad because the body has its own mechanism of balancing the intake and output. So, but if you overheat the system, then the system fails, and therefore avoid taking too much. Cut down to moderation or less. And the urate stones are usually in children and adults who take a lot of red meat. So red meat is something that one has to avoid. There are also other things like chocolates that one can avoid to increase your oxalate content in the body. Now, that is prevention, okay? Of course, you need to keep your urine diluted by taking a lot of fluids, but seek treatment for the stones. Only uric acid stones may pass out on their own, but otherwise most of the stones will need treatment unless they're less than 5 millimeters in size. If they're less than 5 millimeters in size, they might come out on their own. Sometimes they come out without you knowing about it. And sometimes when they come out, even your neighbors will know about it because you're in so much pain and agony. So that is one of the problems with the stones. And that time you need to find out whether your kidney is obstructed or not, whether you need emergency treatment or you need conservative treatment that way. If it's a big stone in the kidney called stag-on calculus, then there are quite a few ways of taking it out. One is by laser, one is by what is known as percutaneous nephrolithotomy, which is putting a tube into the kidney and then breaking the stone with either lithotripsy or by laser and then fishing the stones out. And then there was another way of treating stones called extracorporeal shockwave lithotripsy, which is just blasting the stones from a machine outside the body. But that is good for stones just about 1 centimeter in size or so.
And sir, a lot of times children in our family are having an issue of frequent urination. So do they need to be tested or is it normal for them?
So children at a young age, usually they have nocturnal enuresis, which means leakage of urine in the night, and also known as night bedding. So what they do is they wet the beds in the night, and that happens due to a lot of reasons. One of the thing is maybe due to hormonal changes. There is an antidiuretic hormone, as I said, that is produced, vasopressin, and that is not very effective at that time, and the cells have not matured for them to make that hormone, and therefore the urine is produced at the same level at the day and in the night, and therefore more urine in the night. And if they are sleeping very deep, they don't have the chance to wake up and go to pass urine. The adults will wake up and go and pass urine. Therefore, one of the ways of treating that is by an alarm system. So wake the child up every 2 hours, make them go and pass urine, and that way it can work. Many times there could be an underlying factor of overactive bladder or some neurological disorder. So if the frequency is happening during daytime, quite significantly, that needs to be investigated, especially from a neurological point of view.
Okay. Okay, sir. And sir, two people in our audience have their hands up, Mr. Dinesh Dahima ji and Mrs. Chanda Suntwal. So would you like to...
Yeah, by all means. Yes.
Please ask your questions.
So let's go to Mrs.
जय श्री कृष्ण।
जय श्री कृष्ण।
पॉसिबल है क्या, मतलब कैंसर हो बॉडी में और वेट रिड्यूस नहीं हो, बट बॉडी पेन या उनको साइड सिस्टम सब मतलब बहुत कुछ हो, बट वेट लॉस नहीं हो रहा हो, 150-160 kg के हैं तो?
The weight loss usually
is
the later part of cancer.
लेकिन वेट लॉस नहीं हो रहा है, लेकिन बॉडी में कैंसर सिस्टम है।
कहाँ का कैंसर सिस्टम?
हाथ लेंस का है प्रॉब्लम।
यूजुअली वेट लॉस जो होता है वो कैंसर की लेट स्टेज की फाइंडिंग होती है, एंड बिकॉज न्यूट्रिशन कम हो जाता है।
वेट आके 160 है, लेंस में कैंसर है, बॉडी पेन है, बट वेट बिल्कुल रिड्यूस नहीं हुआ है उनका। मेरा क्वेश्चन ये है, तो ऐसा पॉसिबल होता है क्या? क्योंकि मैंने हजारों केसेस देखे एकदम रिड्यूस हो जाता, पूरा वेट रिड्यूस हो जाता है, बट उनका 4th स्टेज आ गया, वेट रिड्यूस बिल्कुल नहीं, 160 kg है वो।
पर कैंसर एक्टिव है
हमारे?
कैंसर एक्टिव है कि कंट्रोल्ड, ये भी बात है। चीजें होती है वेट के उसमें, वेट लॉस यूजुअली
में है उनके कैंसर क्या
जी
पॉसिबल है क्या? क्योंकि
पॉसिबल है, क्यों नहीं?
ओके बस क्योंकि बॉडी पेन्स उनको मतलब बहुत ज्यादा है, मतलब पूरे नसें और बॉडी मसल्स पूरा बहुत ज्यादा पेन है, बट
स्टेरॉइड्स पे हैं क्या? स्टेरॉइड्स पे हैं, प्रेडनिसोलोन वगैरह ले रहे हैं क्या?
मेडिसिन
से वेट गेन होता है, प्रेडनिसोलोन वगैरह से वेट गेन होता है।
ओके थैंक यू सो मच सर।
थैंक यू। एनी मोर?
There it seems.
I can't hear you, Australia.
Hello?
Yeah.
Yes. Sir.
Yeah.
So somebody else also had their hand up, but I think it was by mistake because now their hand is not up. Mr. Keshav Bhatt has a question for you. He's a known patient of UTI, and initially cystoscopy was done in May 2019 and 6 doses of BCG was given. After this, 5 cystoscopy checkups are done in every 6 months, and now he is suggesting checkup after 1 year. Biopsy result, low-grade papillary urothelial carcinoma, age 63. And the question is, any test required in gap of 1 year like urine culture or sonography, and any thoughts on controlling this by diet?
Okay, so I must say, with all due respect, these are quite a lot of personal questions, and it's difficult to share all this in the public platform. I'll be very happy to answer on a one-to-one basis at any time when Devesh ji suggests.
He can mail us the
because-
question. He can mail us the
Yeah.
question. We will put up to you, and then
Yes, I will be very happy to answer because that's my field of speciality.
ठीक है कैलाश जी.
Thank you. Thank you.
Yeah, you can forward my email address and I will
Yeah,
be very
I will.
happy to.
I will do it, sir.
Yeah, thank you.
Okay. And so one more, Mr. Bipul Ghoshji asked, please explain self-catheterization to avoid blockage in urinary tract.
Okay, well, it's one of the very good ways of preventing recurrence of stricture of urethra. Usually in men, when there is narrowing of the urethra, then what happens is that we divide the urethra internally, passing a telescope inside the water pipe. Just the description of it was to your eyes, but it is just under general anesthesia, so it's not that way. But the only problem is once you open it up, it will cicatrize or come down quickly. And therefore, when you do self-catheterization, you allow the things to remain open. Now, there are various schemes of how to do it and how often to do it. I normally prescribe once daily for 7 days, then twice a week for 3 months, and then another once a week for another 3 months, and then every 6 months or so. It prevents doing what we used to do in India before, called urethral dilatation under general anesthesia. So this is all done at home by the patient.
There are no other questions now. So thank you so much, Dr. Hemant
Thank you.
Okaji. It was amazing having you over here. And,
Thank you. My pleasure.
Keshav. Shreyanjali invited vote of thanks from Keshav.
Now Keshav would like to give a vote of thanks to us. So Keshav, please, can we have you here?
Yes. Am I audible?
Yes.
You are.
Go ahead.
So if you can you stop sharing your screen so we can see Keshav?
Okay, yeah, just a minute now. Yeah, okay. Is that okay?
Yes, sir. Sure.
जैसे पूनम की रात रोशन होती है, वैसी आस आज हर दिल में जगी। जैसी पूनम की रात रोशन होती है, वैसी आस आज हर दिल में जगी है। सलामत रहे यह उज्जवल व्यक्तित्व आपका, आपके आगमन से इस कार्यक्रम की शोभा बढ़ी है। आपके Honorable Speaker, sir, prestigious moderator, ma'am, respected founder, sir, and all the dignified guests. A very good evening to all of you. I'm extremely overwhelmed to be a part of this webinar, and so I would like to express my gratitude towards the founder of Dadheech International Faith Foundation, Shri Devesh Dadheech, for giving me this marvelous opportunity to speak in front of you. Now, on behalf of whole DITF team, I thank Shri Hemant Oja, our keynote speaker, for sparing time and delivering such a fabulous speech on age-related problems. Sir, your speech was really very informative, and the topic was also the need of the hour. Well, I know that between you and your Sunday evenings, but I request our attentive audience to be with me for 5 more minutes, as I have to make some important announcements after the Thanksgiving ceremony. Now, I must mention our deep sense of appreciation for today's moderator, Sushri Shreyanjali Acharya ma'am. Ma'am, it would have been quite difficult to manage today's webinar without your help. Further, we are grateful to DITF's brand ambassador, Sushri Harshita Dadheech. Thank you so much for joining us today. खुशियों भरे इस महफिल में आज अपनेपन का एहसास हुआ है। कि खुशियों भरी इस महफिल में आज अपनेपन का एहसास हुआ है। आपकी गरिमामयी उपस्थिति पाकर यह कार्यक्रम खास हुआ है। आपकी पाकर यह कार्यक्रम खास हुआ है। Well, ladies and gentlemen, an event like this could never ever be possible without having an attentive audience like this. So, on behalf of the whole DITF team, I like to acknowledge our gratitude to Dr. Subhashi Dadheech, Sushri Divyaji Dadheech, Shri Sunil Kumarji Daima, Shri Shailendra Ojha, Shri Varunji Daima, Srimati Chandraji Sutwan, and all those who took time from their busy schedule and attended the webinar. Dear guests, I took immense pleasure in informing you that on 2nd of October, we are conducting a webinar on how to build a successful career, and the cricket tournament organized by DITF is scheduled on 4th and 5th of November. Now it's time to bid you all a goodbye. It was really amazing to have your company today. Once again, I mention my heartfelt thanks to all of you. Goodbye.
Thank you. Thank you.
Thank you very
Thank
much.
you.
Yes.
Thank
Thank
you.
you, sir.
How are you, Subhashi? Thank you so much for joining. बहुत अच्छा लगा। आप म्यूट पे हैं सर।